So relevance of topography in management of astigmatism is my talk today. These are my financial interests. But before we go into the understanding the topography, cylinder of from the topography, we have to understand the basic of astigmatism. The two important things for a refractive surgeon, one is what is manifest, and the other one is the tomographic astigmatism. Manifest comes from your refraction. The tomography comes from your pentacam or any topographers which you use. You can use the true net power, the total corneal refractive power map. These are the ones which looks at the posterior anterior cornea and algebraic sum of it. This is something which we all know, the orientation of axis, what is with the rule astigmatism, what is against the rule astigmatism, and what is oblique astigmatism. All this are something which we have been aware of, and I don't want to go into this. What is a sphere made up of? Sphere is made up of your refraction, your myopia or hypermetropia, which is defocus, and your spherical aberration. What is cylinder made up of? Lot of aberrations, of which astigmatism is one, secondary, the comas, trefoil, and the mix of all this. That's how the cylinder is made up of. That's why this is very complex to understand, because it's mix of multiple things. What is a total astigmatism? The cornea from your anterior, the posterior cornea here, the epithelium, place the internal, and your lens. All this makes up the total. It includes the epithelium also, and the lens and everything else. This is a simple example of this. The anterior corneal, the posterior corneal, look at the axis, and the internal is the lens and your epithelium. Even the epithelium also contributes to the cylinder. Now, if you look at this division here, in this case, the epithelium does not have any cylindrical component. It's zero. It's more of sphere. That means a minus 0.5. It's a perfect epithelium. The total corneal is mix of anterior, which tells you this is your cylinder. In that, it tells you these are the higher order aberration, and also it has a small amount of posterior, which is completely on the opposite side, which is how it works. And your internal, this is from the lens. You can see that a healthy one, which gives you a perfect cylindrical component, which is the lenticular one. When your epithelium is regular, you don't have a cylinder. But when your epithelium is irregular, this is a contact lens patient or a dry eye patient, what you see here is this forms a cylinder here. And this amounts to a diopter of cylinder. So it is important to understand the epithelium in understanding the cylinder, because normally we look at the corneal surface and we look at the posterior surface and we say this is what is the corneal cylinder. But if the epithelium is irregular, and some places this amounts for this change out here. Look at this change. This is your corneal. It's a 2 diopter astigmatism. The epithelial thickness is irregular, and this amounts to 1 diopter from the epithelium. And this is very important for us to understand, because out of this 2, 1 diopter is from your optics, the other 1 diopter is from your epithelium. So this is a very important statement which every refractive surgeon should be aware of in your practice. And this is what you probably would be seeing when you're actually going to treat this patient. And if you don't understand this, you may have a very unhappy vision. This is also the second thing is when your manifest refraction does not match with your topographic astigmatism. Now, question is why? For example, this is your refraction. This is your measured. Measured is your topography. Measured is topography. You can see here it matches. Here, topography is more than the manifest. Here, manifest is more than the topography. Now, what do we do with it? How do you go about with this? This could be misalignment. It could be irregular cornea, tear film, opacities, or lenticular. For example, when the topolizer measured is equal, that means your corneal, if you're looking at this cornea and your lens, what I'm measuring here is the accommodation. This is very important because to understand the cylinder, you have to measure the accommodation properly. So if your cornea and lens are all very synchronous, then you get this kind of a picture. If your cornea, if your lens is more than accommodating more than the cornea is more than the lens, then you get this kind of a picture where the topography and astigmatism is more than the manifest. Here, what happens is your lens is red. This means you are accommodating more. So the lens is more than the cornea. That means your subjective refraction is more than the topography. So topography more than manifest, manifest more than topography. Remember this very clearly. When this is more, that means that the cornea is at culprit. When this is more, it means that your lens is at culprit, because this accommodative changes are very important in understanding these scenarios. And this exactly picturizes it. This is your cylinder from the topography. And you can see that they're all measured from the cornea. They are all topographic cylinder. And this you can see is whatever is coming here is from your topography. And you can see that this is the topography once, which is coming from the topography. Those the topography is more than the manifest out here, which is very important. Here, it's a very important one. The topography is normal, but the lens is one which is having the more thing. So that means manifest is more than topography. That means you have to be very careful in this patient, because this patient may be having an accommodative spasms or pseudo accommodative issues or convergence or accommodation excess. Very, very important scenario is this. Never forget this part, because if your topography says 1.5 diopters of cylinder, but your patient is accepting 3 diopters of cylinder, that means you are in trouble. And then you have to be very careful. These are the patient you need very, very, very good cycloplegic refraction, fogging, and do every kinds of stuff. And in these cases, when everything matches, 1.4 diopters matching with this, 1.2 diopters is higher, that means topography is higher, that's okay. But manifest higher is always a big challenge. So this is an important point for a refractive surgeon. So how do you treat the cylinders? Basic approach, these are all the approaches we have known. When the manifest is exactly what I said, oblique. These are all the scenarios, of with the rule, against the rule, manifest more, topography more. Remember one thing, there are only 2 scenarios. Manifest is more or a topography is more. You have to figure out how do you go about with this. Because if you create and with the rule astigmatism to an against the rule astigmatism, the patient will be terribly unhappy. But against the rule becoming with the rule, he's happy. So always remember this part of it very clearly. And this is just the scenarios for all refractive surgeons. So what do we do? Always keep the same direction. Never make ones with the rule to against the rule, and try not to overcorrect. And you can always correct sometimes. If it does against the rule, with the rule will always be better, not the other way around. And how does the laser surgery today correct? This is a very important question. All the cylinders today are usually corrected on the plus cylinder axis. Even if you have a -3 at 180 degrees, the machine, what it actually corrects is always +3 at 90 degrees. This is how it corrects. And it's important for us to understand. So these are all how the lasers corrects. But look at this. If you have even a -3 cylinder, the machine automatically makes it as a plus cylindrical form, so that it does not, it ablates in the periphery. It is always, it ablates more on the weaker axis to make it, to make the flatter axis to become steeper. And look at this. Even like I said, this is a simple example of this, and this is how the machine actually works on the laser. So I'll just go to this pattern. Yeah, this is a very important thing. Let's assume that you're treating a -2.75 at 5 degrees. How does the machine do? It completely transpositions itself, which you don't know. It actually treats a -2.75 sphere and +2.75 cylinder at 90 degrees. When you put in your machine, any of your machine, this is how a machine treats, because it saves tissue and it's a very perfect one. So first, what does it do? It treats your myopia. So you'll be surprised, you'll have a pattern like this on your laser machine. You'll be wondering, why is the machine burning here? It's because the machine actually transpositions itself, treats the -2.75 in the center, and then it treats the +2.75, even though your power you're correcting is only 2.75 cylinder. That is, this machine always corrects like this. And look at this. At 2.75 ablation, 40 microns, and the central ablation here is 0. So still your peripheral ablation is around 45 microns. This is why your microns. This is how a machine treats, and this is exactly how it's correct. I don't want to go into this. This is an example of how an oblique is treated or a mixed astigmatism is treated. So in summary, this is how all the treatment of your ablation is for a simple myopia, simple myopic astigmatism, compound myopic astigmatism, about how they actually treat in this. So how does Contura work? The Contura works in 3 levels. It looks at manifest cylinders, how the difference is. It looks at the subjective cylinders and also looks at all the 3 parameters which I just described about the manifest and the total astigmatism. It also looks at the aberrations, and it also adds aberration to this profile, and then it makes planning according to how you want to treat. So all these are different types of it, which I don't want to go into this in this presentation, but we build a software, we incorporate everything, and this is only for the Contura, which incorporate all that I discussed here, including transposition in some cases, how it treats, and all you have to do is feed in. The machine has its own algorithm to treat and take care of it very well. This is just a paper which you have submitted, just shows how good this kind of a software is. To summarize, understanding cylinder is very, very important. Rule 1, when the manifest is less than the topo-guided topographer astigmatism, both in the same axis, less than 10 degrees, always treat the manifest astigmatism. Remember this, manifest less than topography. That means topography more than the manifest. Always treat less than 10 degrees. And treat rule 2, when there a manifest is more than topography and both are within the rule astigmatism, treat always the topography astigmatism, because the topography astigmatism is the one which compensates and always compensate for spherical equivalent. And then if you increase the topography, change the sphere. That's all everybody knows about it. If the manifest is more than the topography astigmatism and with the against the rule astigmatism, treat the manifest and convert the topography into with the rule. That's something which you can plan. And rule 4 is manifest oblique, treat the topography. If it's an oblique, treat for topography with the spherical equivalent, and adjust the manifest and with least astigmatism when they are different from more than 10 degrees. Thank you, and thank you, Kudlu sir, for this opportunity.